Hi everyone, welcome to Diagnosis Bona Curatio Bona, and today's topic is lower abdominal and pelvic pain in women. And at first, let's talk about chronic and acute pain. So, acute pain, if you see a woman which is sexually active in her mid-20s and she distressed by the pain, and you also mentioned that she has some abnormal uterine bleeding. The first thing that you have to suspect is an ectopic pregnancy. Also, it could be PID or pelvic inflammatory disease, rupture or torsion of an ovarian cyst, and acute appendicitis. Chronic pain is constant or recurrent pain of at least 6 months duration, and the pain can be cyclical, for example, like for endometriosis or Mittelschmerz, it's a rupture ovarian follicle, or pain could be continuous. Chronic pain is more difficult to diagnose, and it's often difficult to differentiate between problems like endometriosis, PID, and ovarian neoplasm, and the irritable bowel syndrome. And today we will talk about 4 conditions: the ectopic pregnancy, acute torsion of ovarian cyst, endometriosis, and pelvic inflammatory disease. So let's get started. Ectopic pregnancy, and it's a pregnancy that is located outside of the normal intrauterine location, most often in the fallopian tube. And risk factors for ectopic pregnancy are previous PID, previous abdominal or pelvic surgery, IUSD use, it's intrauterine contraceptive device, and intravitreal fertilization. So clinical features are its pre-rupture symptoms are cramping pains in one or other iliac fossa, vaginal bleeding, and after rupture these fallopian tube symptoms could be like excruciating pain, circulatory collapse, and also there are 3 main symptoms. It's amenorrhea, lower abdominal pain, and abnormal vaginal bleeding. So it's possible to diagnose ectopic pregnancy at a very early stage of pregnancy using urine pregnancy test. And if serum beta HCG more than 2000 international units per liter, it should be visible on vaginal ultrasound. If you see that urine is empty, so most likely it's ectopic pregnancy. If it's less than 2000 international units per liter, so you have to repeat every second day to see if it's increasing normally as expecting in a normal intrauterine pregnancy. Transvaginal ultrasound can diagnose at 5-6 weeks. So, and if you see that empty uterus, tubal sac, fluid, and cul-de-sac, so, and it means that possible that it's ectopic pregnancy. So, and this we can see ultrasound women who have ectopic pregnancy. So it looks like here. So it's a fallopian tube, and this is ectopic pregnancy here and here. So treatment may be conservative, medical by injection intramuscular methotrexate, laparoscopic removal, or laparotomy for severe cases. The next is acute torsion of ovarian cyst, and this torsion occurs in the setting of an adnexal mass, so it could be a functional ovarian cyst, a dermoid, a pertubal cyst, benign or malignant neoplasm, and this mass changes the motion dynamics of the adnexus such that the twisting of the adnexus becomes possible, and symptoms are severe cramping, lower abdominal pain. This pain may radiate to the flank, back, or thigh, repeated vomiting and nausea, excruciate pelvic tenderness, Signs are smooth, rounded, mobile mass palpable in abdomen. So the best choice for diagnosis, it's a pelvic ultrasound. Also, you can feel this mass on examination, and treatment just laparoscopy and surgical correction. Endometriosis, it's when the endometrium is present outside of the uterus. The average time to diagnosis is 10, maybe even 16 years. So there are a lot of clinical features. The main clinical features are dysmenorrhea, menorrhagia, dyspareunia, and abdominal or pelvic pain. And I also want to tell you these clinical features, the symptoms. So it's dysmenorrhea, infertility, deep dyspareunia, and painful abdominal bloating. And now I want to show you this graphic. So it's, as you know, dysmenorrhea, it's a pain during the period. You can see this pain for endometriosis is quite different, and it begins before menses and ends after menses. For example, for other cases of secondary dysmenorrhea, this pain ends with the menses. Also, there is a primary dysmenorrhea when we don't know the cause of this pain, and usually it's during the entire reproductive period of women. And its duration just maybe 2-3 days at the beginning of the menses. And also there is pain between periods. It's distension of ovarian capsule pain and Mittelschmerz, or it's a rupture of ovarian follicle. So the gold standard for diagnosis, it's a direct visual inspection at laparoscopy. You can use transvaginal ultrasound, may identify ovarian endometrioma or rectal endometriosis, and curettage shows small sensory nerve fibers in the endometrium. Of course, if you use medical treatment, you don't actually treat this condition. It's just release symptoms and even doesn't improve the candidate. So excisional surgery for endometriosis is usually the initiate treatment of choice, as it improves the symptoms and also confirms the diagnosis and improves the quality of life. Treatment, it could be medical, contraceptive pill, levonorgestrel, releasing IUCD, or Mirena. Surgery, it's a laser surgery, diathermy, ablation, and excision of endometrial tissue via laparoscopy. So, and the last one is pelvic inflammatory disease. It's an infection of the female reproductive system, which includes the womb, fallopian tubes, and ovaries. The causative agents are chlamydia, trachomatis. Actually, it's the most common one. Neisseria gonorrhea, Mycoplasma genitalium, Mycoplasma hominis, and clinical features are there is acute PID and chronic. So for chronic, it's a fever more than or equal 38 degrees of Celsius. Also moderate to severe lower abdominal pain. For chronic PID, it could be ache in the lower back, mild lower abdominal pain, and for both acute and chronic, it could be menstrual problems like painful, heavy, and irregular periods, intermenstrual bleeding. It could be also vaginal discharge, so it could be abnormal, perhaps offensive and purulent discharge, painful or frequent urination. The diagnosis of pelvic inflammatory disease should be made on clinical grounds. And if you just suspect pelvic inflammatory disease, so you have to immediately prescribe antibiotics. And Next, investigation, it could be endocervical and high vaginal swabs for microscopy and culture, but it also shouldn't delay treatment. And even negative swab results do not rule out the diagnosis. Pelvic ultrasound if you suspect abscess. So treatment, if it's a sexually acquired infection, mild to moderate infection. So it's ceftriaxone with metronidazole and doxycycline. If it's a severe infection, ceftriaxone with azithromycin and metronidazole. If it's infection not sexually acquired, and if it's a mild to moderate infection, amoxicillin with clavulanate and doxycycline. For severe infection, it's a amoxi or ampicillin with gentamicin and metronidazole. For complications of pelvic inflammatory disease, infertility, chronic pelvic pain, and ectopic pregnancy. This is the end of this video, and it was Diagnosis Bona Kuratse Bona, and see you next time.